Well, greetings everyone and welcome to the EKG case for the week of July 1st, 2012. This week's case was provided by a young emergency physician by the name of Nicolina Anderson, who's from Sweden. I had a chance to meet her at the ACEP Scientific Assembly in San Francisco this past fall, and she sent me a couple of very nice cases. A very nice young lady. And this was one of the interesting cases that she had sent me. It was a 90-year-old man that presented with chest pain, and he has a pacemaker. Now, the layout of the EKG that I guess they have in their hospital or in Sweden has a little bit of a different format, so you need to just take a look at it for a second. All of the normal leads are there, and I got rid of the rhythm strip because it wasn't really relevant in this particular case. But if you just take a quick look at it, it's got all of the usual things that you'd expect. You've got V1, 2, 3, 4, 5, 6 laid out vertically here. And then out in terms of the limb leads, you've got lead 1, 2, 3, and then AVR, AVL, AVF. So everything's there. It just takes a moment to get accustomed to it. Now, many of us have been taught that when you've got a pacemaker, you cannot read any evidence of cardiac ischemia into that EKG, and Dr. Anderson was smart enough to pick up something a bit more than that traditional incorrect dogma, and that there is something else going on here. We actually reviewed acute MI in the presence of a pacemaker back on February 12th, 2012, so just a few months ago we reviewed this topic, and for those of you that recall, this is one of the EKGs that we reviewed at that time. So you can go back and review the February 12th EKG videocast that we did back then. But this was another really nice case to just review. So anyway, let's first of all talk about what you normally expect to see on a pacemaker. There is something that we like to refer to as the rule of appropriate discordance. And everything I'm about to say is the same type of stuff that we talk about with regards to reading cardiac ischemia or infarction in the presence of a left bundle branch block. Left bundle branch block patients have this thing called appropriate discordance, and so do pacemakers. So here's an EKG. This is provided by Dr. Jim Campana, who's a former graduate of our program, who sent this EKG from a 38-year-old, I think 38-year-old woman who is having an infarction. This was her baseline EKG, and we'll just review what we normally expect to see with a pacemaker EKG. What is this rule of appropriate discordance? Essentially what it says, or what it means, is that every time the QRS is mainly pointing north or upwards, you expect to see just a little bit of ST segment depression, or maybe, it can be isoelectric, and that's fine also, but in every lead where the QRS is pointing upwards, you're going to see just a little bit of ST segment depression or an isoelectric ST segment. All right. Every time the QRS mainly points downwards, all right, and there's a whole bunch of leads here in this pacemaker where the QRS mainly points downwards, you should expect to see a little bit of so the QRS is pointing downwards here. You expect to see just a little bit of ST segment elevation, or isoelectrics okay as well. And that is what we refer to as the rule of appropriate discordance, and that should hold true in every one of the 12 leads on this EKG. Every time the QRS mainly points upwards, the ST segment is isoelectric or a little bit below the baseline. Every time the QRS is mainly downwards, the ST segment, or J point, is going to be isoelectric or a little bit above the baseline. Now, back in the mid-1990s, cardiologist by the name of Elena Sarbossa reviewed a lot of EKGs and came up with these, what we refer to now as the Sarbossa criteria. These are probably more validated for left bundle branch block pattern, but there's a handful of studies that have shown that this is also true, and perhaps maybe even a little bit better for reading ischemia or infarction in the presence of a in the presence of a pacemaker. Essentially, when you lose that appropriate discordance, you are with very high specificity looking at a patient who's got a myocardial infarction. So, if you have what's referred to as concordant ST segment elevation, in other words, there's ST elevation in the same direction as the QRS. If you see ST depression in the same direction as the QRS in leads V1, V2, or V3, or If you have ST elevation in the opposite direction, normally that's okay, but if you have too much ST segment elevation in the opposite direction, then that's considered an infarction pattern also. All right, so going back to this baseline, actually let's skip over this and let's go back to Dr. Anderson's EKG. The EKG gives us nice little hash marks to point out the J points. And, this lead and this lead, this lead, this lead, and so on. These are all okay because you've got normal expected discordance of the ST segments, but where is it abnormal? Let's take a look at V1. QRS mainly points downwards, so we expect to see isoelectric or maybe a little bit of elevation of the J point, and that is present, so lead V1 we're happy with. Take a look in V2, QRS points downwards, and what do we see? What we see is that there's just a little bit, actually more than just a little bit, 1 or 2 millimeters of ST depression in the same direction in lead V2. And in fact, in lead V3 also, ST depression in the same direction. That's not good. In fact, Sarbossa says that if you have ST depression in the same direction as the QRS, you're looking at an infarction pattern. And sure enough, that's exactly what was going on here. Leads V2 and V3 are abnormal based on the Sarbossa criteria, and that means this person's having infarction. And what ended up happening with this patient, sure enough, the patient did in fact rule in for myocardial infarction. Now, some of you may also notice that there's ST depression in the same direction in V4 and in V5 and a bit in V6 also. Although we're not going to make a big deal about that technically because that's not part of Sarbossa's criteria. Sarbossa's criteria only talked about ST depression in the same direction as the QRS if it was in V1 or V2 or V3. Now, I would worry about these leads for sure, but based on V1, V2, V3, this patient meets Sarbossa's criteria, and I think you can make a very good argument to just go ahead and give this patient thrombolytics or send this patient to the cath lab. As I mentioned, this patient did in fact rule in for infarction. Let's go back to Jim Campana's case. And again, you can see more about this February 12th, 2012 EKG videocast that we did. In Jim's case, you'll recall what the baseline EKG was, and in his patient with acute symptoms, chest pain, leads 1 and AVL met Sarbossa's criteria. And this patient ruled in for infarction also. Let's take a look at lead 1. QRS goes north, so we should have ST depression, but instead we've got ST elevation in the same direction. Lead AVL, QRS goes upwards, and again, we've got ST segment elevation in the same direction. So this patient meets Sarbossa's criteria as well. All right, so 2 cases. One of them's a repeat from February 12th, but Dr. Anderson is provided with yet another case of a patient with an acute MI in the presence of a left bundle branch block pattern. So once again, Sarbossa's criteria originally applied to left bundle, now can be applied to pacemaker EKGs as well. If you see ST elevation in the same direction of the QRS complex, like we just saw here in AVL and lead 1, if you see ST depression in the same direction as the QRS, in V1, V2, V3, as we saw in Dr. Anderson's case, or if you see ST elevation in the opposite direction, but too much, by more than 5 millimeters, then that also is fairly specific for a myocardial infarction. And I think there's reasonable evidence now to say that you can go ahead and thrombolyze that patient or to send that patient to the cath lab. All right, so pacemaker in the presence of acute infarction in the presence of a left bundle branch block pattern. Yes, you can make some conclusions about ischemia or infarction in contrast to the traditional teaching. All right, so my thanks to Dr. Anderson for sending that EKG all the way from Sweden. And also, once again, thanks to Dr. Jim Campana for letting us reuse that EKG for this case. Hope that was helpful, and we'll talk to you next week. Bye for now.